very much. So I'm going to try my best. I actually have a slide on how to replace chemotherapy in this talk. And happy birthday, Jonathan. So these are my disclosures. And I'm the only radiation oncologist in this session. So do we have radiation oncologists in the audience? Do you want to raise your hand if... Oh, well, of course. One of them I know quite well, and very charming lady next to him. So I'm just going to give you a bit of a summary of where we were up to 2017. So the standard of care, as you will know, in unresectable stage 3 non-small cell lung cancer was concurrent chemoradiotherapy. And based on a seminal trial, RTOG 0617, we know that there is no role for dose escalation using conventional fractionation. So by that, I mean 2 gray per fraction. In terms of systemic treatment, cisplatinum-based chemotherapy is the standard of care together with radiotherapy, and we know that there is no role for induction or consolidation chemotherapy based on a number of clinical trials. We also know that up to now, there is no defined role for targeted agents in the context of chemoradiotherapy, including in those patients who have driver mutations, but that may change in the future. There are a number of ongoing trials in this field. And then, of course, we had the so-called immunotherapy tsunami in 2017 with a publication of the Pacific trial, which completely changed the standard of care. So I'm sure this distinguished audience will know all about Pacific, but just as a bit of a recap. So this was done in an all-comer population, so irrespective of PD-L1 status, so patients who had unresectable disease, who had no progression after chemoradiotherapy were randomized 2-to-1 between 1 year of durvalumab versus placebo. And the 5-year survival was recently published. And as you can see, there is a very significant reduction in the risk of death. So 38% reduction in the risk of death and 45% reduction in the risk of progression or death with durvalumab. And most of the subgroups actually benefited, at the exception of the patients who have driver mutations, EGFR mutations, and also there was a not pre-specified analysis of the patients with PD-L1 less than 1%, and that led to the approval of durvalumab in all comers in the US and in Asia, but in Europe and in the UK, the approval is only in patients who are PD-L1 more than 1%. So there's quite a lot of controversy around that, but that's the situation at the moment. And this slide summarizes the progress made in the last 3 decades with better integration of systemic treatment and radiation. And you can see that there's been steady progress in terms of 2-year survival, from 10% survival in the 1980s all the way to 66% nowadays with concurrent chemorads and durvalumab consolidation. But of course, in addition to changes in the field of systemic treatment added to radiotherapy, we've also had a very significant evolution of the radiotherapy treatments and improvements. So most of you here are not radiation oncologists, but you will know that we have more conformal ways of treating patients, particularly with intensity modulated radiotherapy and volumetric arc therapy. We have 4D CT to take into account the breathing motion, PET-CT to target particularly the lymph nodes that we need to include in the radiation field. And we have so-called cone beam CT on the linear accelerator, which means that we can check accurately that we're delivering the high-dose radiotherapy to the target. And we have a number of important clinical trials that have been done in recent years, helping us to define how to better deliver treatments. So we've learned from this recent study from Germany, the so-called PET plan study, where patients were randomized between delivering radiation only to the area that was PET positive versus the PET positive area plus elective nodal irradiation, but actually there is no detriment in terms of survival to deliver radiotherapy just to the PET positive region. And that's actually really important when you're thinking about combining radiotherapy together with drugs, particularly immunotherapy, as we know that these large fields can lead to lymphopenia and potentially detriment in terms of the efficacy of the immunotherapy treatment. But can we go further? And one of the quite provocative questions is whether we could, in this example, just focus the radiotherapy on some of the disease and perhaps not necessarily treat all of the lymph nodes that are positive on PET in the context of the addition of a treatment such as immunotherapy. And then another really important trial in our field is Oncology 0617. So not only we've learned from this study that high-dose radiation does not improve outcome. In fact, the outcome was worse, but we've learned something really important there is that we have to limit the dose to the heart. And one of the important prognostic factor was the heart V5, so the dose delivered to the heart. We also have another factor, the heart V30 that came that was significant in the multivariate analysis. So it is important to avoid the heart. We've done a lot of work in this field in Manchester using image data mining analysis, and we have demonstrated that the area that matters most is the base of the heart, so the top of the heart, where the conduction system and the origin of the coronary arteries is located. And that has now led to a program of work in my institution where we have, as of April 2023, implemented a dose limit for the first time to the base of the heart, and we're using really innovative methodology, so-called rapid learning cycles, using real-world data directly collected from electronic patient record, which means that we don't have to use a clinical trials unit. We have no strict eligibility criteria, so we can include all patients, including those who are elderly, those with comorbidities. Patients do not sign a consent form, so they can opt out from the data collection. The actual implementation of the dose limit to the base of the heart is a clinical decision. We've also learned the importance of the hard dose from the lung-out trials. The lung-out trial was in patients who had a complete resection and were randomized between 55 gray post-operatively and no radiotherapy. And in this study, there was no significant difference in disease-free survival, which was a primary endpoint. Also, no significant difference in overall survival between the two groups. There was, however, a very significant reduction in the risk of mediastinal relapse. But what's really important from this study is that we've again learned about the importance of irradiation of the heart. So in the port arm, there was an 8-fold increase in the risk of patients dying as a result of cardiopulmonary toxicity. So again, some further evidence that limiting the dose to the heart is really important. And then I had the brief from Jonathan, who wanted to, who asked me whether we should consider giving some upfront induction treatment prior to chemoradiotherapy. So the answer, Jonathan, is not yet. So this is one of a trial. It's actually quite an old trial from CALGB that randomized patients between chemoradiotherapy alone versus induction. Chemotherapy was paclitaxel carboplatin followed by chemorad, showing no difference in survival, and the other trials similar to this that did not demonstrate a benefit. We also know that some patients will progress on chemotherapy and that may compromise their chemoradiotherapy. However, I think there is a real question around chemo IO induction as well in this setting, and that is certainly an academic question, but also in patients who have driver mutations for sure. Trials need to be done to give induction EGFR TKIs. There was an RTOG study many years ago that unfortunately failed due to poor accrual, and there are other ongoing trials at the moment. And in the field of unresectable disease, we have many gray zones. I'm not going to go through all of that, but we have questions around the patients, so selection of patients, partly the elderly, patients with poorer performance status, patients treated with sequential chemorads, for example. And then with regards to the tumor characteristics, there are questions around the benefit from the addition of immunotherapy in tumors who have PD-L1 less than 1% and obviously driver mutations as well. There are many questions around the timing of chemo, RT, and immunotherapy. So should we deliver the IO concurrently as well as in the consolidation setting? How soon should we start immunotherapy after chemoradiotherapy and so on? They're very important questions about other drugs. I mean, durvalumab is certainly the standard of care currently, but there are many other trials ongoing with other drugs. And then importantly, selection. So can we use ctDNA radiomics to tailor immunotherapy consolidation treatments? And the good news is that there are many trials, as you can see, ongoing to address all of the questions on the previous slide. Now, so this is for Natasha, who is somewhere around. Oh, hello, Natasha. So can we get rid of chemotherapy? Well, the answer is we're doing it in the UK. So this is a platform study called Concord, where in patients who are suitable only for radiotherapy or sequential chemoradiotherapy. We did not start this in the concurrent setting due to concerns around toxicity. So it's an early phase trial with multi-arms combining DNA damage repair inhibitors and radiotherapy. And we have a control arm, which is quite unusual in the early stage setting. And we are hoping that potentially we could, if we have interesting results on this phase 1 study, that we can move on to later phase study to potentially replace chemotherapy, and immunotherapy is obviously included in this platform. So conclusions. So concurrent chemoradiotherapy followed by durvalumab is clearly standard of care in fit unresectable patients with stage 3 non-small cell lung cancer. I've showed you that there are many gray zones and ongoing clinical trials. And the way forward for me is actually to combine systemic therapy and radiotherapy in an optimal way. And that probably means radiotherapy de-escalation as opposed to radiotherapy escalation. So for example, limiting dose to the heart, limiting dose to lymph nodes, and then finally combining novel agents such as DNA damage repair inhibitors with immunotherapy and other modulating drugs. Thank you very much for your attention.